Hey there, hi there, ho there. Good morning and afternoon, everyone. Thank you for joining us for our second Ask the Expert. We're glad that you joined us. Our first one was kicked off by Dr. Adams, and we were speaking about stroke. Today, moderated by Dr. Keith Carollo, we have our second Ask the Expert, Dr. Marcia Treadwell. So we're pretty excited about doing that. My name is Dr. Carolyn Rowley, and I am the Executive Director and Founder at Cayenne Wellness Center. And again, I'm glad to welcome you and have you join us. We take care of persons diagnosed and living with sickle cell disease in California, all throughout California. We're known in this space for the educational programming that we put on, such as our new Ask the Expert. We do our mini seminars. We've done the brain, sleep, mental health, reproductive health, and holistic health. This year, we're focusing on fatigue and legal implications, as well as mental health again. This year as well, we hope that you can join us for our 15th annual Sickle Cell Disease Educational Summit, which is going to occur in September, September 13th through 17th in Los Angeles. So if you can join us, wonderful. If not, we'll also be holding that virtually. We'll also be doing our third annual Hispanic Heritage Sickle Cell Disease Educational Seminar. Last year was just so wonderful. It was excellent. And so we're looking to having everyone come back and join us again. We're also known for, so in addition to the educational programming that we do, we also have two initiatives. Our Mental Health and Wellness Initiative that we launched last year, uh, which means that those persons diagnosed with sickle cell disease in California have access to free mental health, so free counseling, free health coaching, and free naturopathic consultation. We're excited. Um, Along those same lines with the mental health, we also, as of this month, we can also now take on our children, pediatric patients, starting from ages 9 through 17. We're excited about that. We also have a new initiative called STAC, STAC, which stands for Sickle Cell Trait Awareness Campaign, which has been launched here in California. And this is focusing on, we want everyone, for right now, those who are living in California, to know their trait status, know what's in their genes. So our campaign targets middle school, high school, and college age students. We're excited about that. And that actually began in January, and it's a 5-year public health campaign. But back to our program for today. You're in good hands. You're going to be the Ask the Expert will be moderated by Dr. Keith Carollo. We're going to bring him on right now. And our special guest is Dr. Marcia Treadwell. You're in good hands. I'm going to turn it over, and you all will see me towards the end. Thank you so much.
Hi, and welcome to this special presentation by Dr. Treadwell. There are CMEs available for this program, and the objectives are what constitutes racial bias in sickle cell disease treatment, what is the impact of racism on the treatment and outcome of people who have sickle cell disease, can healthcare providers assess themselves for implicit bias, and what constitutes a safe place for people who have sickle cell disease. So we'll give you more information about the CMEs later on in the program. I'd just like to introduce Dr. Treadwell, who sent us a very modest bio that I'll read verbatim, and then I'll tell you the rest of the story. So Marcia Treadwell is a professor of pediatrics at the University of California, San Francisco. She received her doctorate in child psychology from the University of Washington in Seattle. She also received advanced training at UCSF in research. So UCSF has a special program for people to do research, and it covers all the aspects of research, and she finished that program. She is an internationally recognized person who, and her program is research focused on populations affected by sickle cell disease and how social determinants, psychological and behavior factors, and organizational structures and processes impact their health and well-being. Marcia has, I've known Marcia for 30 years, so so Marcia has published numerous papers, and she's been, I can't even, hundreds, right? Probably. And she's she's addressed many national and international conferences in Europe and in this country. She's gone to Africa and helped people in Africa cope with sickle cell disease. She's an amazing person, and that's her introduction. She's going to talk to us about racial bias in sickle cell disease, and I'm looking forward to this.
Well, thank you so much. And I'm really delighted to be here. To have this opportunity to talk with you about something that is just so important and that has really received renewed emphasis in recent years. Next slide. So it's important to think about sickle cell disease as really an integrated, holistic phenomena in terms of how people with sickle cell disease are affected. I think there's been lack of real understanding about how complex sickle cell disease is from a medical standpoint, but it's also very complex in the elements that really influence those medical outcomes. And so you can have structural factors such as structural racism, you can have environmental factors such as climate, sociocultural factors such as social determinants of health, anxiety, depression, stress, those all interplay with pain and complications of sickle cell disease. And then behavioral, how physically active are people? So you've heard a lot about these holistic elements of sickle cell disease through Cayenne Wellness. And again, I'm going to be talking specifically about the lens of racism and healthcare disparities. Next slide. So the CDC has outlined how you can think about sickle cell disease health disparities in terms of health outcome disparities, which refer to how the medical condition directly affects the length or quality of a person's life, and then resource disparities. So, an important health outcome disparity is that even in 2023, the life expectancy of people with sickle cell disease, the most severe form, can be up to 30 years shorter than that for people without sickle cell disease. People with sickle cell disease have the highest rate of readmissions within 30 days, which of all conditions in the US, they have the highest rate of 30-day readmission. And then the rate of stroke and many other complications is quite high in people with sickle cell disease. Next slide. So, examples of health resource disparities or disparities related to materials, personnel, facilities, funds. The majority of people with sickle cell disease in the US are Medicaid beneficiaries, and this may limit their access to physicians who accept Medicaid. I will talk more detail about how people with sickle cell disease have longer wait times when they seek emergency care for pain. And the number of physicians who care for people with sickle cell disease, particularly those who are adults, is limited. So those are health resource disparities as opposed to health outcome disparities. Next slide. Most of you do know that an important manifestation or a common manifestation of sickle cell disease is pain. But as I said, it is complex and there are multiple complications that occur. But in terms of the sickle cell pain experience, sickle cell disease is different from almost all other pain syndromes. there's an onset in infancy. So an exposure to medical trauma, exposure to pain that's unremitting, exposure to opioids. Providers overestimate the risk of addiction for patients with sickle cell disease. There is evidence that there is not a higher rate of addiction for people with sickle cell disease, but it's consistently overestimated by providers. And patients and families, in turn, report that they're discriminated against, misbelieved, and mistreated within the healthcare system. Next slide. So, our topic today is on biases in sickle cell pain management. So, I want to talk with you about a study that Carlton Haywood, a sickle cell warrior, completed. He and his team reviewed more than 170,000 emergency department visit records. They wanted to look at wait times for people with sickle cell disease compared to patients with long bone fractures and other conditions. And what they found was that people with sickle cell disease did experience wait times 25% longer than the general patient population. Race did play a factor in this as well as the sickle cell disease diagnosis. And then compared with long bone fractures, people with sickle cell disease waited 50% longer than the patients who actually had fractures, even accounting for race and assigned triage priority. Next slide. So another way that racism can manifest and impact the care for people with sickle cell disease is in language. So people will call, or providers will call people with sickle cell disease drug seekers or sicklers or frequent flyers. When interns and residents were exposed to that kind of language in a chart, so they were exposed to either stigmatizing language or neutral language. And when the language was stigmatizing, you can see on the right that they were significantly less positive in their attitudes towards patients with sickle cell disease. So that's that PASS score that's looking at attitudes. And then in terms of their reported pain management, they were less aggressive in their pain management when they were exposed to the stigmatizing language. And that's the lower chart. Okay, next slide. An interesting study that was just published, it was on behavioral flags. And so again, this is an example of structural racism or care that's really mediated by the provider's implicit biases. So in a single healthcare system in Pennsylvania, the authors looked at almost 200,000 patient charts. And what can happen is that patients can get these behavioral flags in their charts, and you can see an example of that on the right, or how it's entered. And basically what it does is it says this person is aggressive, or this person, look out for them, that kind of thing. It's negative. A behavioral flag is quite negative. And they did find, consistent with racism in this country, that Black patients received behavioral flags at 4 out of 1,000 patients, whereas for white patients, only 2.4 per 1,000 received these behavioral flags. Now, when you compared Black and white patients with the behavioral flags, then the Black patients in turn had longer wait times. They had longer wait times to see a clinician. They had fewer laboratory and imaging tests compared with white patients with a flag. But the shocking thing about this study is that they couldn't even include people with sickle cell disease in the study because they had too many behavioral flags. So that was what was striking really about this study, that patients with sickle cell disease were even more likely to receive behavioral flags compared with other Black patients. And you can see how this impacted their care. This is how racism manifested. Next slide. We're starting to really think about how does this stigma related to pain um, treatment affect people with sickle cell disease directly. So beyond the wait times, beyond the fewer lab tests, those are really serious. And how does a person receive this? Well, when adolescents with sickle cell disease were asked, have you been stigmatized or treated unjustly? They actually reported worse pain. They reported worse pain coping, which is what the catastrophizing refers to. They reported more functional disability, so less ability to just function day to day, and emotional stress when they were asked, how do these injustices affect you? People when they're treated unjustly will be less ready to seek needed health care. And we've seen this over and over in our program, where people will say, I'm going to put off till the very last minute seeking health care because I've had such bad experiences. And there's beginning thought that there's actually an underlying neurobiology of stress in the context of chronic pain and pain-related stigma. Next slide. So let's back up a little bit and talk about what is bias. So, bias is just a way for us to make sense of the world. There's lots of information coming in. So, we do have to quickly categorize information that comes into us. So, bias occurs, it's an automatic response, it's a shortcut to interacting with the world. But the problem is when you have a judgment about something and you accept it as a fact. Next slide. So, unconscious bias or implicit bias are out of our awareness. They're out of our intention. They're out of our control. And these biases often conflict with our conscious attitudes. So we may feel that we're the most open person in the world, or we're the most accepting person in the world. And yet do still have biases that we need to pay attention to. And I'll talk later about how we can measure implicit biases. Next slide. And also, I'd like to point out that race and ethnicity are social constructs. So race isn't a biological construct; it's a social construct. It's based on a hierarchical human grouping system that's meant to identify, distinguish, and marginalize some groups. It divides human populations based on physical appearance, social factors, and cultural backgrounds. And then ethnicity is also a social grouping. Next slide. So, how do we mitigate these biases? They arise outside of our control, outside of our awareness. As providers, person-centered care is going to be a really important strategy to mitigate bias. If we're looking at patients and thinking about treating them with dignity, respect, supporting self-determination, then this can make a big difference. But let me move into more specific strategies. Next slide. First, we have to be aware of our biases. And there is an implicit association test, which is computerized. And what it does is it asks you first to categorize um, adjectives that are positive or negative. And then you start to match these adjectives with faces or images. So in this case, you would see an adjective good, and then you would start to match up these adjectives versus bad, and you would match up positive and negative adjectives as faces come on the screen. And some of the faces are black, as you see in the upper row, and some are white, as you see in the lower row. And so the implicit association test really looks at how quickly you match the adjectives. And so the thinking is that if you take a little bit longer, then there's a bias because you're trying to, maybe filter your response. So anyway, the implicit association test has been used quite widely and pretty commonly and is available online. Next slide. So that's the first thing, to recognize that we have biases. And you can do it by taking the implicit association test. And there are other ways to just recognize and stop and think, do I have a bias against a certain individual? In this case, African American individuals with sickle cell disease. So as you are thinking about, do I have the bias in the first place? Then you can consider, I have a bias against, let's say, a young person with sickle cell disease. I expect them to behave a certain way. Rather than going to that place, in your behavior, you need to pull back and consider, well, I'm thinking about that this young person maybe is going to have some behavior problems because I have this bias against young people with sickle cell disease. But you pull back and say, well, this person is in college, this person is an artist, this person is a niece, um, um, daughter. And so you identify counter stereotypical exemplars to your bias. Further, you start to think about not categories of people, but that this is an individual person in front of you, and that all young people with sickle cell disease do not behave the same way. All people with sickle cell disease in pain do not behave the same way. And we also think about how you are, what you have in common with individuals. Practice taking their perspective. And finally, really think about how we can all grow if we are embrace and understand that we have these biases, but that there are strategies to mitigate them. Next slide. In terms of sickle cell pain, again, starting with a philosophy, patients want and deserve optimal pain relief and the best quality of life. And in the acute setting, this means listening to them and respecting their self reports. Although pain may be the admitting diagnosis, sickle cell disease is complex, and other symptoms and potential complications should be evaluated. Our decisions need to be based on assessment, not on how the person looks or how the person is behaving. So, what's the pain assessment? Where's it located? What's the intensity? What has the person used in terms of their outpatient analgesic use? What does the person know works for them? And individualized pain plans are extremely important, and perhaps we can talk about those more in the question and answer. Next slide. An anti-racism framework is another framework or philosophy to start with. And so the elements of an anti-racism framework is to name it. And we name that racism exists, that people with sickle cell disease, that these biases are because of structural racism, because of interpersonally mediated racism. So racism exists, it's a system. It saps the strength of all. And the importance of using an anti-racism framework is that people, again, do want to feel that they have the best intentions and that they should be embraced for doing the best that they can. They didn't go into medicine to treat people badly. However, if they step back and understand that they're part of a structure and a system, and that racism has been part of this country since its inception, then we can move forward if we start there by naming racism. And these historic injustices need to be recognized and rectified so that resources need to be provided according to need. We didn't get into a lot of detail about another fundamental disparity in sickle cell disease, and that is funding. So there has been a real lack of funding in terms of reimbursement for care provided, funding for research, philanthropic funding. So these resources now we need to step up and provide these for the sickle cell population. And this is a really exciting time in terms of disease modifying therapy, curative therapies, but we can't lose sight that people with sickle cell disease have lacked access to quality care since it's been identified in Western medicine. And so while these curative therapies are important, it should not be the sole focus. So we have to work together, again, to dismantle racism in terms of structures and policies and personal responsibility. Next slide. The last framework that I'm going to describe to you is called cultural humility. And it is can be distilled into these 5 R's. First, reflecting, so that we approach every encounter with humility. So there's no such thing as a frequent flyer because every encounter is unique and we can learn something. We treat people with respect at all times. It doesn't preserve a person's dignity to expect them to complain about pain in a way that they aren't used to or not be stoic if that's how they manage their pain and manifest their pain. So respect preserves dignity always. We hold every person in the highest regard, and again, are aware of our unconscious implicit biases and how these could interfere in an interaction. We expect that cultural humility is relevant to every patient and every encounter. And through this cultural humility framework, we develop resiliency. Our patients develop resiliency because of this globally focused compassion for ourselves and for others. Next slide. For patients, for people with sickle cell disease, there are now better avenues that can help you in terms of speaking up should you experience discrimination. And your philosophy is, I have the right to timely and appropriate care that is free from discrimination. Let me repeat that. As a person with sickle cell disease, you absolutely have the right to timely and appropriate care that is free from discrimination. You have the right to be treated with courtesy and respect. And if English is not your preferred language, you have the right to an interpreter. And this comes from the Joint Commissions that accredits healthcare facilities. Next slide. If you feel that you're being discriminated against and are experiencing substandard care, this Joint Commissions initiative is entitled Speak Up. So find out about your hospital or healthcare policy for reporting complaints. There's something called incident reporting that will, first know your rights, and second, use these incident reporting systems to report your complaint. And there should always be a patient advocacy department. Check that one out. Again, you can submit an incident or you can reach out to your patient advocacy department. You can also file a complaint with the Office of Civil Rights. Next slide. And the Joint Commissions wants to hear about it because, again, they are accrediting healthcare facilities. So they offer the capacity for you to submit via this link, your concern, or by mail. Next slide. The Joint Commission and your hosts here believe that everyone deserves to be treated with respect. So again, speak up. It is your right. And by doing so, you may be helping future patients, not just yourself. And I think that's it. I meant to keep my remarks brief so that Dr. Carollo could interview me and ask me questions, as well as the audience. Thank you.
Thank you so much, Marcia. So what I want to do here is to just talk about, we're going to start the QA and remind everybody that this is a CME. You can actually watch this later on. So if anybody has any questions, please address those. And in the meantime, while we're waiting for questions, I'm going to question Marcia. So it's extremely common that adults with sickle cell disease have a difficult time finding healthcare, finding doctors. I think they're more discriminated against than younger people, even in adolescence.
Yeah.
So how do you, in terms of this topic, how do you describe that reality? Is it like a disparity, bias, racism? It's a big thing because people are not trained to take care of people with sickle cell disease. So that's a whole thing. Like the ASH, the American Society of Hematology, is trying to increase the numbers of hematologists rather than oncologists. But can you just say something about that? What you think? What your impressions are?
Definitely. I would say it's all of those things. So if we think about what racism is, then again, it is a system, but the system is people are in the system. And so when people have these implicit biases, then they structure the system in a way that creates these disparities. So we start with funding for sickle cell disease, and that there's a magnitude of hundreds of times more funding for other conditions compared with sickle cell disease. So that's a structural racism issue. And then care for adults with sickle cell disease. Um, this society, has these views of adults who are African American, and will stick. We know that sickle cell affects people who aren't just African American, but in this country, that's sort of the face of sickle cell disease, which isn't necessarily a bad thing, um, but in turn, because there are such racist views of adults who are Black and African American in this country, then that really does undermine the care of people with sickle cell disease. So that when an adult walks into an emergency room, they're labeled a drug seeker immediately, as opposed to being assessed and understood what their concern is or what their medical complications are. And then the issues of people going into care for patients with sickle cell disease, that goes back to finances as well. That adult hematology didn't pay as well, honestly, as other specialties. And then the last point is that just sickle cell disease was a disease of childhood, and so the adult world wasn't prepared to take on people with sickle cell disease as they aged into adulthood and the senior years. But again, then overlaid on all of that is a structural racism of this society that does have these biases against adults who are Black and African American. And there are disparities in so many other areas in terms of healthcare for adults who are Black and African American.
So, kind of a follow up to that would be, can you say, you kind of touched on this in one of your slides, but to me, it's almost there's an element of PTSD, post traumatic stress disorder, among people who have sickle. I mean, you can't
Mhm.
escape that.
Yes.
You're Black, and you have this. Uh, you face racism every day, even outside of the hospital system.
Mhm.
And then when you come into the hospital system, you face more of that.
Mhm.
And I don't have sickle cell, so I can't say, but I think when people come into the emergency room, like you said, they're very sick. They don't come
Mhm.
in early, they come in
Yeah.
late. And the people I've talked to, they're actually afraid they're going to die.
Mhm.
They don't know, they're not, if the pain isn't this pain that they usually appreciate, and they've taken all the medicine at home and they're still in pain, they're scared when they come into the hospital. So
Mhm.
I think can you just talk about PTSD and how that would affect people with sickle cell disease?
Yeah, that's a really important insight. And I think it's not been another thing that hasn't been well appreciated about sickle cell disease is that um, people have been exposed to really traumas since a very young age. First, an infant may experience pain, and that can really, impact their experience of the world, because the world is supposed to be safe and comforting. And so to have pain that's unremitting can really be hard for an infant. And then maybe the infant is stuck with an IV and is stuck more than once because it can't be placed by an expert. And then maybe the infant is away from their parent for some hours, and then this repeats over and over. So those are medical traumas. And it doesn't mean, again, that people can't overcome these medical traumas or can't overcome traumas, but it's just that you have to have this level of compassion about it and understanding and an ability to really consider that the individual has experienced traumas and that it's not easy. Again, the audience certainly knows it's not easy living with sickle cell disease, but if you start to conceptualize it really as as traumatic experiences. And then on top of this, then you look at the television and you see Blacks and African Americans being murdered. And this is, you're a young Black man and you could walk out the door and this could happen to you. You're a young Black woman and someone could shoot you in your home. So these things are real, and these things are what we live with as Black and African Americans, and have to really um, foster resilience in order to cope with these things. But yeah, trauma is real and it's ongoing, and it needs to be recognized and addressed.
There is a question waiting, but I just want, is there a structural way, or is there any structure to address PTSD? I mean, we all talk about mental health and that sort of thing, but to me, PTSD is kind of like it's a different animal
Mhm.
because it's caused by something.
Yeah.
If you're depressed or whatever, that is caused by something, but PTSD is like trauma. It's like
Yeah.
somebody did something to you. How is that addressed in the
There's thinking, the new way approach in terms of medicine is called trauma informed care. And so, what trauma informed care does is intentionally tries to avoid inflicting more trauma on people who may have experienced traumas. So if you label someone, or if you keep them waiting, or if you come in the room and you're rude and disrespectful, that is the opposite of trauma informed. So you're inflicting more trauma on top of the traumas that the person has experienced. So in trauma informed care, you really take that step back and understand that you have to be more supportive and you have to be respectful, and you keep in your mind all of those elements of cultural humility so that you don't inflict additional trauma on the person who's visiting you.
and is that is that a process that's available in hospitals? Is that like an organized something that is done in hospitals generally, or is that sort of more theoretical than reality?
That's a good question. So, in our at Children's Hospital in Oakland, we are intentional, and at the Benioff Children's Hospitals. So we're intentional about trauma informed care, and we're working. You maybe want to look on websites for different institutions and see if they are working towards an anti-racist framework or a trauma-informed framework. And so I can speak for where I'm working, which is that we are really trying to instill this trauma-informed throughout the whole enterprise where I'm working. Now, people aren't perfect. The structures aren't perfect. Medicine isn't perfect, but I think that there's just a better recognition in medicine about this important element that again, it's not a physical. I think as you look at health more holistically and look at how there are different influences on health, then you understand that these behaviors, both on the part of the provider as well as the person who is the patient, um, there's an interplay, and then that ends up manifesting in the disease complications, and they can be worse, or some can come up that wouldn't have been there because they're of a stress history, that kind of thing. So I think that yes, in medicine today, I think there is a better recognition of both the need for a partnership between the people and the families that we're working with, as well as concepts like trauma informed care.
So the question that came in was, though one can file a complaint overall, the sickle cell disease community wants to be believed for their pain, to have the healthcare providers know when to do. Oh, there we go. Know when to do a differential diagnosis when there's something other than pain going on. Ultimately, they want to live and not die. Yes, well. And what can what can the patients and caregivers do to change the course at their hospital where they receive care?
Hmm. Um, well, first, I do want to acknowledge that people with sickle cell disease deserve the type of care that the person who asked the question is asking about. So this should have been what people could just expect going into the healthcare system, but it's not. So I think that um, knowing your rights is the first step in all of this, and again, I appreciate that people may feel, or and it's happened that you go through these complaints or you talk to your community health worker, but I would just encourage you continue to do that. Um, you do want to live, you don't want to die, and these practices need to be put into place in the healthcare settings. And the best way to do it at this moment in time is its advocacy. So if you can't advocate for yourself, which often you can't because you're ill and in pain, uh, work to have a family member or a friend with you when you have to go into the healthcare setting. And then the next step might be, again, a community health worker, such as from Cayenne, who can help advocate for you. The other point I would make is people do get discouraged when they face these issues constantly. I would encourage you still to try to find an outpatient provider who's a sickle cell expert. And what that can do for you is another advocacy voice. I know that some areas there aren't as many adult providers as others, but work to find someone because sadly, the other provider on the emergency room is going to listen better maybe sometimes to your provider than to you or your advocate. But let's just, leave aside the injustice and unfairness of that and start to move forward to say, okay, it's my right to have good health care. So again, I'm going to have a team to advocate for me and with me. And yeah, so I that's what I would say about that. Hopefully that makes sense.
So, the other kind of part of this question is um, the provider's knowledge about people with sickle cell disease and not believing their what they're telling them. And this happens with Black people. It's now very common. Everybody should know that the mortality rate among women who go to have children in the hospital and their children
Mhm.
themselves is higher than any other group in the whole country.
It is. It
And
is.
it's because, I'm just guessing, this is my opinion. It's because the physicians taking care of the patient does not believe when the patient tells them they
Mhm.
have a problem. And a very famous person was complaining about chest pain, and
Mhm.
they had a pulmonary embolism, and they
Yes.
were kind of blown off.
Right.
So how um, how I don't know how really to address that because I mean my experience with taking care of people with sickle cell disease is it's really complicated. There, like you've alluded to, there's so much involved medically and socially. Um, and I think maybe you could say something about the training program you have at Children's, the
Mhm.
boot camp
Yeah.
for
Sure. Absolutely. So it's known in medicine, and this is another point about structural racism, that there's very little attention that's paid in medical school to sickle cell disease. And it's been marginalized as and underestimated in terms of what it's really about and how complex and it is. And so what we offer at our through our sickle cell center is a boot camp, and so we do bring in providers. At one point, it was in person; it's been virtual for a bit. And we just teach them about sickle cell disease and about how complex it is, really, how every organ system can be affected. And by the end of their time with us at the boot camp, they definitely have a better understanding of that. We have people with sickle cell disease speak about their experiences. We talk about the context of healthcare disparities. And so that does help. So education does help. And again, the question about how can we change the course at our hospital, it does take advocacy, and it does take activism. And if we think about the history of sickle cell disease in this country, the activism of the Black Panther Party in the 60s is how sickle cell disease really came on the radar, and the comprehensive sickle cell centers got funding. So activism is a part of what is important for us to do as providers, researchers, and people with sickle cell disease and family members. And so within a given hospital, again, do that incident reporting, talk to the patient advocates, but also I've had many requests for us to go and speak to the emergency department providers, to set up a patient panel where, when the person is feeling well, okay, you went and had a bad experience in the emergency room, and come back when you're feeling well with let someone from the Comprehensive Sickle Cell Center to do a presentation to the emergency department. That can go a long way to changing attitudes as well as behaviors.
Yeah, I think that's really important because in the emergency room, especially, they only see people with sickle cell disease when they're in some kind of a crisis, pain or some other thing. And so their impression of people with sickle cell disease is they're always like this. They're
Right.
always, they can't imagine, and again, this is my opinion, but they can't imagine that this person who's in front of them is like a normal person
Mhm.
who has a family, has
Yeah.
children, has whatever. And just the vision, just realizing that, I think changes your concept or your impression of people with sickle cell disease. There's no other questions, but I have questions all the time. So you did a PLOS1 article that was cited barriers for care, um, and this it what there was lack of knowledge, lack of empathy, lack of easy access to appointment. Um, and some of these barriers were similar to the displaced study, the
Mhm.
TCDs. So
Mhm.
I saw that those two studies sort of dovetailed a little bit,
Mhm.
because the difference in the displaced study than what you did was a lot of the providers wouldn't make appointments because they didn't think the patients would make the appointment.
Yeah.
And the reason
Mhm.
why they weren't making appointments, they didn't have any transportation, they had
Mhm.
kids to take care of, their lives were so filled that sometimes they miss appointments. And so can you just sort of talk about that a little bit?
Yeah, we've been talking about bias in the acute care setting, but that's bias in the outpatient setting, so that the provider makes an assumption. The person looks a certain way, or uh, you know, mothers who will talk about their experience where they're professionals, but and they come in with their husband, and everyone dresses a certain way so that they aren't look in their sweats or whatever. They have to look like professionals when they come in, because the provider has a bias when they see a Black person in sweats. And then I was going to bring up the example of another a parent who said that if she was alone without her husband, then there was assumption that she didn't have a husband. So there's these assumptions that do happen, and they do seriously impact care, because children, quality of life and lives are affected if they don't have that stroke screening. And yet the provider is making an assumption about whether or not the person is going to follow through and make it to their appointment without having evaluated what the social determinants of health might be that are interfering with the appointment. So, again, the questions a question that is coming in, and I think we keep getting back to, is how can we change this at our hospitals? And I think that I keep saying advocacy. Advocacy is important. So these are great ideas, and how can they be policies that hospitals must follow? And there are different ways to approach this. So in our own hospital, I'm also the co-chair for the Diversity, Equity, Inclusion, and Anti-Racism Council for the Benioff Children's Hospitals. And so we look at not just these implicit biases on the parts of providers, but the structures that are in place because Western medicine is inherently racist. A structural remedy to challenges on the acute setting for people with sickle cell disease is individualized pain plans. So that is a structural remedy to this acute problem. And basically, a study that we just completed looks at how you put the individualized pain plan in the electronic health record. You put it as well easily accessible through the patient portal. And then it cuts through that provider's lack of belief in whether or not the person's having pain or how much pain medicine they should get, because it's an official document. That's a little bit different than what you're asking. I mean, so there are two pieces. Again, providers need to be forced into educating themselves about their implicit biases and about how to mitigate the biases that do occur. And in fact, in California, because of exactly what you just said about earlier about Black infant mortality, there is in fact a new law about nurses need implicit bias training because there's absolute evidence that Black infants are dying at an unacceptably high rate. And so given that, finally, there's legislation that nurses have to take anti-bias training because we're recognizing that their bias is not, and providers' bias, not just nurses, can influence, these kind of outcomes. So you can take it hospital by hospital. You can take it federal legislation, such as the Chris Van Hollen bill that is looking towards funding sickle cell centers around the country. You can look at the work that we're doing with the National Alliance of Sickle Cell Centers, where we're starting to recognize sickle cell centers as being up to a certain standard. We don't have a formal designation yet, through joint commissions or through whatever of what is a comprehensive sickle cell center, but we're starting to name it. So we're making progress. We do have some momentum. And so this is the time when people really need to advocate to get these things into policies and practice.
Yeah, in California, it sounds like what you need is legislation. It doesn't
Yeah.
sound like hospitals are going to comply with something that's not either legislated or the Joint Commission
Right.
making this happen. So what can the public or the people with sickle cell, their advocates, what can they do to influence legislation? I mean, that you have to know who your legislator is,
Yeah.
and then you have to go to them and advocate for people with sickle cell disease. But in terms of I've always thought that the Joint Commission, if it will give special acknowledgement to ICUs, cardiac care, this and that, but they've not done it for sickle cell. How does that, if they did do it, then you would immediately know this hospital isn't Joint Commission certified for sickle cell disease and this one
Correct.
is. How do you see that? How do you influence the Joint Commission to do something like that?
Well, that's a very good
That's a hard
question.
one.
That's a hard one. I would, I presented information about how if you're, they have this speak up if you've been discriminated against. So they have this initiative. I think that people need to avail themselves of that initiative. So I think we need to widely advertise the initiative and then have people uh, submit their concerns as they come up. So I've been at patient and family workshops and so on where people will say, I get tired, and sickle cell disease is fatigue is part of what's happening, or I deserve this kind of treatment and it's not coming to me. And people do get tired. I get tired, but we have to just kind of set up a kind of a tag team where we can all work together to advocate. So think about it, it can be again exhausting to advocate over and over and over again. But if you think about how geese are flying north or south, wherever they're flying for the winter, and there's one in the front, and then when that one gets tired, it drops back and another one comes to the front. And so that's how flocks of geese make it to their destination. And so where us as individuals can really feel like I'm just tired of this and this is ridiculous and I've been doing this for years or decades. But if we work together, I think we really can make it happen. And if we educate ourselves, so submit these complaints to the joint commissions and submit, why don't you take this on, and go from there and see what happens.
So Carolyn just noted that the Joint Commission did have a sickle cell certification program similar to like stroke and ICUs. There it is. But only one hospital in Ohio
Oh.
was actually certified. But I don't know that they still have that program. Maybe they do, but I'm not aware of that.
Yeah, I mean, we're talking about the joint commissions, but let me there is other activity that we can get behind, I think, at this moment in history. Um, so first, the National Alliance of Sickle Cell Centers. There are now 76 centers that are aligned with best practices in pediatric and adult care. And so the National Alliance of Sickle Cell Center, the president is Julie Cantor. There's a board of directors from all over the country. Um, and and we're working on consensus recommendations from the literature. So the National Alliance of Sickle Cell Centers it's at its beginning stages. It's just 2 years old, but to have 76 centers who are attempting to or already adhering to some standards is a great start. And I think that sort of an organization could be supported to continue on if the Joint Commissions isn't going to take this on. The other thing I'll confess to that we're working on is that so the Health Resources and Services Administration funds these treatment demonstration programs, again, in 5 regions in the US. So the whole US and territories are covered. And we really talk a lot with HRSA about the need to I guess there's a reluctance to actually certify programs, and we need to think about why that would be. I don't know the answer to that. But if we can get HRSA to not fund programs if they aren't providing this care in a certain way, which is comprehensive sickle cell specialty care, or would only fund if you are recognized by the National Alliance of Sickle Cell Centers, for example. I think that's the future of where we want to get to, is that there is an alliance that is certifying or recognizing centers.
I think there's another question. There it is.
Okay, calling out biases when they're happening. Thank you for that question, Lynn. Hi. Anyway, um, yes. So there are 2 sides to this. So first is allyship. And so, what allyship really refers to is that it really requires the people who are not always the target to step up, to speak up when there's an issue. And in this case, that would primarily be white people. So not it's not just on underrepresented represented in medicine minority populations. Again, it's exhausting for us. We shouldn't always be the ones who have to speak up. So we need to establish both allyship, where people who are not minority or not the targets of racism open up to understanding what their biases are and taking that next step to be trained to interrupt bias when they see it. So it takes a ability of teams in hospitals to have dialogues about differences by race, ethnicity, and language, and then just giving people specific words to use to interrupt the bias. And so, okay, you're sitting there in the charting room, and your colleague says, oh, there's a Jim again. He's a drug seeker, and so I'm just going to make him wait. So, what do you do as the provider who is next to that other provider? Um, you can use those same strategies. So on the one slide where I talked about strategies to mitigate bias, you interrupt, or you also counter. And so you could. So what are some things you could say? You could say, recall, here we're trying to really work within an anti-racism framework, and so be careful about what you're saying about that patient. You It's important to think about them every time as being unique in terms of your encounter. So just use the language of an anti-racism framework, of cultural humility, of mitigate strategies to mitigate bias, and just interrupt it. Now, sometimes it's hard in the moment. So but still, as soon as you can, get back to that person and say, the other day you were talking about, the patient as a drug seeker, and I really want you to read this article that talks about the challenges when you use that kind of language. And then if you still don't get satisfaction, you could put it in incident report. Now, incident reporting that's a feature of all hospitals. So, because they're set up generally to be about safety. And so it's important in hospitals where you do say, there's the person didn't wash their hands before they started accessing that person's line. But you could also put into the incident reporting system, nurse X repeatedly or even once wouldn't listen, or was discriminatory in their language and biased in their language. And then their behavior was even more biased when they made the patient wait unnecessarily, and put that incident in, and they're confidential. And I think we just have to all step up and speak up.
Okay, there's another question that's going to come up.
Systemic racism. That's okay. Very good question. That's where we have to influence policies and procedures. And as I said, in sickle cell disease, an example in emergency medicine is individualized pain plans. So do what you can to make sure that those plans are implemented. And also, what I would say about that is, just putting plans out there doesn't solve the problem. Providers have to be educated about the individualized pain plans. They have to be created in a systematic way. So, where the outpatient provider creates the individualized pain plan with the patient and then houses it in the electronic health record. So you're just countering the structures. So structural racism is what causes a person with sickle cell disease, or is the context for a person with sickle cell disease walking into the emergency room, being labeled a drug seeker, and then having long wait times, being undertreated, and leaving, and having to return within 30 days because they weren't treated properly in the first place. So that structural racism needs to be named, and then it needs to be countered at more than one point. So one point is an individualized pain plan as opposed to no plan at all, or anti-bias training so that the provider is aware of their biases of making that patient wait. Quality improvement programs where you demonstrate this population of patients is waiting 50% longer than this population of patients. And so we need a concerted quality improvement project to change that. Yeah.
There's another question, but real quick. Didn't at Children's, you actually shortened the wait time.
Yes, we did.
Maybe talk about that just for a second. Then we'll see
No,
the question.
that's a quality improvement project that I had in mind. So, yeah, in our own emergency room that is partnered with a comprehensive sickle cell center, we saw that unacceptably, we did a chart review. So every patient with sickle cell disease who came into the emergency room for a year, you can go back in electronic health record and see the length of time it took for them to get treated. And we did find that although people weren't waiting hours and hours and hours, they could wait up to about an hour. And again, they shouldn't have to wait that long. And so what we did was presented the data to the emergency department, the physicians, the nurses, and we established a plan to address it. So one part of the plan was changing the triage priority. So people are familiar that you go to an emergency room and certain gunshot wounds or heart chest pain, those are high priority. But sickle cell disease now has been elevated to at least the second priority. It used to be very low. It didn't have a priority rating at all. So now it's at least the second priority. And then in the pediatric emergency room, we were able as well to talk about using intranasal fentanyl, which is safe, used in an emergency department. And that shortened the wait time, and so that it became half an hour to as low as 15 minutes. So we did it by awareness, education, changing the structure in terms of immediate treatment, and then implementing individualized pain plans where possible.
So we have another question. That's
Thanks, Sheila. So presenting information to medical students. I think that systematically presenting information is still our challenge. I do present once a year to the medical students at UCSF, and they also are beginning to. We're expanding our Sickle Cell Center of Excellence, and so we now have a hematologist who's presenting on a much more regular basis at San Francisco General Hospital, and so as all. I would say systematically across the board at medical schools, that's still an area where we need some advocacy, and where there definitely needs to be some improvement in, what medical students understand about sickle cell disease. And so I would say the message really is, again, that it's complex, that it's not just about pain. It's about sickling that damages the organs and leads to a shortened lifespan. But when pain is untreated, that creates further complications. So untreated pain as well is a real issue, and so pain needs to be interrupted. Pain needs to be treated, but sickle cell disease is very complex, and the whole person needs to be treated.
right. So it looks like there's no more questions, but can you say something? When I read the article about the behavioral flagging, which I didn't really it didn't exist when I was writing the EMR. to me, that sounds very arbitrary, and sort of, it sounds like it could, the way it was presented was there was no checks and balances. It's just like somebody doesn't like a person and they just flag them, and then it stays there forever. Is there
Yeah.
what if things like that happen, they're internal, like no patient would know that. So
No, they wouldn't.
how do you how would a physician how do you is there a how would you address that if you were like working in the hospital and I saw that and I said, "Oh, wait a minute, that doesn't work. I don't like
Mhm.
that." How do you look at the systemic racism within an institution? You're part of the institution. How do you address
Yeah. Yeah, that article just came out, and it's problematic on so many levels,
that?
as you're saying, and, uh yeah, so I think that part of our all of our personal responsibility is to influence policy where we can. And yeah, I honestly I didn't think about it either. I mean, I knew there were flags, but I didn't think about disparities based on race, ethnicity, and language. Although we have at our hospital, we did look at calls to security. This is kind of a common problem again, unfortunately, in healthcare in the U.S., where people of color, when there's a security call, then it's more likely to be on a person of color than on a white person. So, but again, you have to take the personal responsibility to speak up when you see that. So when you see it happen, ask questions. So as a healthcare provider, we have to ask those questions. Does this go beyond this one incident that I'm seeing where, you know, the you call the security or you put a behavioral flag in on a black person, and yet I don't see you doing the same with the white patients who have the same behavior. So you start with that, just the individual, and then you take it to the next level. So what is this? And so I do think in healthcare that encouraging quality improvement projects is always a good thing, because quality improvement is it's a cornerstone. That there are offices in every hospital now that are called continuous quality improvement. So you just try to get a quality improvement initiative going to ask the question. And if there's no difference, say, okay, what the question is there a difference by race in my hospital in these behavioral flags? If you don't find it, wonderful. But if you do, then you have your work cut out for you, because you need to set up a quality improvement project to recognize, when is that flag being placed? What was the behavior when the flag was being placed? How does the provider need to be educated to not do that automatically? How do you remove the flag? Those kinds of things. So I would advocate strongly for quality improvement, because that is an area in healthcare that is common, and that we can concretely address some of these issues.
And we have about 10 more minutes before we close up here. So can you say something more about the sickle cell centers that you talked about before, how we can find information about those? How's it organized? Who's behind it? Is it ASH or some other? How does that? How give
Yeah,
more information about it? That
sure.
I like that. I really
Yeah.
want to know more about that.
So, Ash, again, I mean, I like to be optimistic and positive, even though I'm talking about I'm talking about structural racism, but I am naturally optimistic
And
and
she is.
positive. Anyway, so we've been slowly building some momentum. It's been more rapid in recent years. So the American Societies of Hematology did start these workshops where they were educating providers to become adult providers for sickle cell disease, since there have been so few. And then next, these workshops were focused on establishing comprehensive sickle cell centers based on the knowledge that we have currently. From those ASH workshops, this National Alliance of Sickle Cell Centers grew out of the ASH workshops. And so the National Alliance of Sickle Cell Centers, and I am one of the officers, so I'm the secretary. Um, we wrote an article about what constitutes a comprehensive sickle cell center, because throughout this country up to this point in time, any
Right.
it doesn't matter where you could go somewhere and one says they're a comprehensive sickle cell center, and let's say for pediatrics offers TCDs and another one doesn't, and it's like, well, what is that? So we outline both in two articles, one for adults and one for pediatrics, what constitutes a comprehensive sickle cell center. And then from there, we incorporated a 501c3 to create this National Alliance of Sickle Cell Centers, and listed criteria, essential elements of a comprehensive sickle cell center, as well as recommended or preferred elements, knowing that everybody's not quite there yet. And at this point in time, as I said, we have 76 centers that have submitted applications, and the applications have been reviewed by other sickle cell experts. The National Alliance of Sickle Cell Centers has a board, and the board members are from all over the US. We very intentionally aligned with the Health Resources and Services Administration Sickle Cell Disease Treatment Demonstration Program. So all 5 regions are represented on the board. In terms of voting members, there are people with sickle cell disease on the board. There are family members of people with sickle cell disease on the board, who are voting members. And lastly, there are people who are non-voting members, such as the CDC is actually represented. So, so I can send, the National Alliance of Sickle Cell Centers website so that you can visit it and see where the centers are. And this can be something that patients can look for when they are, traveling around the country. Where is a center that's recognized by NASAC? And yeah, in the future, we will want to have a more of a certification process. And we also looked at cystic fibrosis and hemophilia. We looked at conditions that primarily affect white people, and have these systems in place to advocate and support and ensure quality. And so that's really what the National Alliance of Sickle Cell Centers is about. It's not about research. It's about ensuring quality, comprehensive sickle cell care.
We have another question that they're going to post here in a second.
How often should healthcare providers be exposed to bias training? That's an excellent question. Thank you for that question. It should not be a one-off. That I took my anti-bias training 10 years ago, so I'm good. No. I mean, this is where advocacy really comes in. I mean, we this needs to be every day in the healthcare system. This needs to be every day in the world, really. We're lucky to be in California. I know sometimes we don't feel that way, but you know, we are in a state that did put forward this legislation that nurses had to take anti-bias training. They have to take it once a year. We're also in a place where institutions like UCSF, we aren't perfect, and yet we did start this anti-racism initiative, and we're looking towards just having it be a part of everyday healthcare, where it becomes a natural part of the dialogue, and you don't have to get to the place of a incident report, but rather where everyone is aware, where everyone is able to talk about differences and respect differences and appreciate differences. Then you learn strategies that you can just put into play immediately. And when someone says something that's racist or discriminatory, that you're able to interrupt it immediately. We definitely aren't there yet, but we want to get there. And so the question of how often should people get this training? Definitely not once. Once a year is better. More than once a year is best. And then every day, just it's just part of what we do. We recognize that this country was built on the backs of slaves, and that this country continued continues discrimination and continues to function as structurally racist. If we recognize and own it, then we can move forward. But as long as we just feel like it's someone else's problem, or we're good if we have one class, that's not where how we're going to get to a truly anti-racist um, existence.
And I think, I told you my favorite slide that you put up. I think this also, you have to look at it in a global way.
Mhm.
If you can't accept the fact that what we're talking about, racism, you know,
Mhm.
that is this country was really built on, then you it's difficult to imagine that you can give compassionate care
Mhm. Yeah.
to anybody,
Yeah.
not just Black people, not just
Exactly.
people with sickle cell,
Right.
but everybody.
Right.
And the goal of medicine should be to see just exactly what was in that slide. Every person is an individual.
Right.
Every person deserves your respect. Every
Right.
person has a story that you should know
Right.
because they are a human being and you're taking care of them. You may blow it off because you're a doctor and you think, oh, this is okay, that's going to be fine. But that person doesn't know that.
Right.
You have to really have empathy and compassion and treat each individual person with every single encounter
Yes.
to get as much information as you can so you can take the best care of them. And I think this can be broadened to just, I mean, medicine is the history of medicine, as you can see in the back there, that those two books on the top is not pretty. So
No,
we
it's not.
really need to reevaluate
Mhm.
what we're doing as doctors. And I think the most glaring, egregious aspect of it is Black people, minorities, sickle cell. I mean, that if you
Yeah.
can't fix that, then you can't fix the whole system.
Yeah, no, it's really true. And I think that, again, you have both the cultural humility, but then you recognize that these inequities are built into the
Right.
system that we're functioning in. And it was really stark with COVID-19 as well. I mean, look at Latinx, Blacks, people were disproportionately affected by a virus that should have not been disproportionate, but it was because of the healthcare system that we're functioning in. And sickle cell disease, yes, has been characterized by disparities since it was identified in Western medicine. But we have momentum now to advocate on the individual level, on the hospital level, and on the state and national level.
Okay, I think we have reached the end. I keep looking over here to make sure I'm on time here. Um, so I'm going to adjourn the meeting. I really, really appreciate you coming on, Marcia. This has been a very enlightening and beautiful presentation.
Well,
Um,
thank you so much for asking the questions, because again, it's important to ask the question to name the problem.
yeah,
And then that's the way that we can begin to address it.
right. If you don't ask the question, you're never going to get. It's not going to happen. Yeah, it's a big issue. Yeah. Anyway,
Well, I want to interject as well. I think, as Jasmine has asked, in terms of how frequently one should get training, I think it's the same for organizations like Cayenne to continue to bring these types of educational webinars and programming to everybody. So often is the answer, often. Dr. Keith, once again, great moderating. Appreciate you. And then, Marcia, you're wonderful. Um, I think we really appreciate, seriously, we really appreciate how long you've been in the community. I have to say, I don't think that the sickle cell community knows that you're in a lot of sickle cell spaces. And like you said, you're secretary for the ASH, but you're in a lot of spaces so that you hear, so that you can actually bring it to us. And so for that, we're very thankful. Of course, we're going to do this again. I think, Dr. Keith, I want you to just share with the those who have are doing the CME what they actually need to do at this time, if you can share.
Right. Okay. So if you want to, if you want, there's the link. If you want to get CMEs for this, you need to respond to a test, and that link will be sent to you. And you have to do that before March 31st. And you have to attend, you have to have attended the meeting. So this will be online for a month about, and anytime you watch it, if you can apply for CMEs and get CMEs for watching this program. I would really encourage people to tell their other people in their hospital and even and patients to this is really an important issue.
Yes.
And we really need to get this word out. And the information that we got from Marcia today is invaluable. And we have to act on it. We
Yes.
can't just listen to it and think it's fine. It's not fine.
Exactly.
So
I do want to be able to say that this recording is available for everyone. For
right.
those that actually want to get the CME, you do have a limited period of time to do that. But I do want to say we are in the process of putting together a learning management system where even for previous presentations, a person will be able to get CME. That's actually coming in the next couple of months. So we do want to encourage you all. This recording will be available for everyone. It's chock full of information. Dr. Treadwell, she mentioned several articles that I think are so important. When actions speak louder than words, she referenced that from Patrick McGann and Alexandra Power Hayes, New England Journal of Medicine. They came out in November 2020. Excellent, excellent, excellent. It actually, if you, I want you to read it. And then at the end, there are actions that one can do, that all of us can do, both as a patient or a sickle cell warrior, healthcare provider, and even an institution. Highly recommend that you do that. Also, Jeffrey Glassberg's article on improving emergency room care. That's something that the entire community can look at. And it speaks to what Marcia is talking about as well, in terms of being able to be seen within the hour, being able to be um, assessed periodically every 30 minutes or so. These are ideal, but it's going to require all of us to be able to start a revolution um, to bring about change. So, with that, I want to say again, thank you for joining us. This is really important. We do this because the warriors, healthcare providers have they email us, they text us, they call, and in terms of what types of programming that they would actually like to participate in and or view. So we're doing this based upon what you've asked for, and for that we're thankful for joining us. Dr. Keith, if you can actually come on back and lead us into our adjourning until next time.
Okay, so we're going to have another, again, we do this for CMEs, but this is for everybody who has sickle cell and all the advocates and caretakers. So this is really important information. And in this program, we actually had actionable things to do. Next month, we're going to have Ebony Lance come on, and she's going to talk about the neuropsych testing and neuropsychology for people who have sickle cell disease. Ebony is an amazing person. She's published a lot, and she knows a lot about neuropsych testing and the brain function in people with sickle cell disease. This is another really important topic for people with sickle cell disease by another expert who has done so much work in this. She is a wonderful person besides, just like Marcia. She's a great lady. So with that, I thank you very much for attending this conference or this meeting, and please share this with your friends. Everybody should listen to what Marcia had to say today.
I agree. And with that, we're out, everyone.
Yeah.
Have a great rest of your Friday afternoon. Thank you.
Thank you.